Hello, everybody, and welcome to today's webinar, When Your Loved One is Hospitalized. My name is Lucy Gerland, and I'm a caregiver specialist with the Fairfax Area Agency on Aging. We today are very fortunate to have with us Pamela Andrews from Inova Health Systems, and I will tell you more about her in just a moment. I'd like you to know that at any time during the presentation, you can ask a question by typing into the questions bar that you have on your dashboard. And I will ask them of Pamela either during or after the session. So please feel free to type in any questions. The session is being recorded, and you will have an opportunity to review it later. The recording will be sent out. Also, you should have received a copy of the speaker's slides, and those are for your reference after this. It's not necessary for you to pull them up while Ms. Andrews is speaking, because she'll be running through them on her computer. So let me introduce a little further Pamela Andrews. Pam is the Assistant Vice President of Case Management at Inova Health System. She has worked for Inova for 18 years, and during this time, Pamela has served in several roles aligned with transitional planning. She has served as Director of Case Management and as Senior Director of Regulatory Strategy and Outreach in the Population Health Medicaid Division. Pamela is a registered nurse, has a master's degree in social work and a master in business administration in healthcare management from the University of Scranton in Scranton, Pennsylvania. Pamela actively serves as the president-elect for the National Board of the American Case Management Association and participates as the past president for the state of Virginia. Pamela also holds a certification in case management from both recognized professional organizations, CMSA and ACMA. And I will turn it over now for this very helpful presentation, Pamela Andrews. Thank you.
Thank you so much, Lucy, and welcome everyone. I will be leading you through this session. I just wanted to describe my role a little bit. My leadership role with the organization is mainly a support role for the case management departments within all 5 of our hospitals. I lead teams of nurses and social workers, and as well as ancillary support staff to help with transitions of care. For those of you who may not be familiar with Inova, I just wanted to include a few informational slides. As you may know, we are a not-for-profit health system. We do have 5 campuses, of which Inova Fairfax is our largest facility, and Inova Alexandria Hospital is our oldest facility. So we've been in the Northern Virginia community for some time serving this population. Also, a number of ancillary services and urgent care centers and support services centers are located in this demographic and geographical diverse community. I will also say, just to note, our community providers include the Inova Medical Group, of which we have greater than 450 physicians, including all specialties, pediatrics, as well as adult services. So that's just a little about us as an organization. I will move now into talking about the learning objectives for this session. And in developing the learning objectives is just thinking about the hospital experience in itself and how it impacts the actual patient and those who support our patients, which is the caregiver community. I want to talk a little bit about the care team, the patient's care team, as well as the care team for those supporting the patient, admission processes. The hot topic that I often get asked about is admission versus observation. Share a little bit about what you can expect during a hospitalization. We'll integrate and talk about community resources and how to access those services, important documents, and understanding your insurance. So throughout the presentation, I may integrate a number of these topics as during a hospital stay, there's a number of things going on at the same time that are in tandem. Therefore, communicating them separately may not give you the total understanding of what you may experience or your loved one while you're in the hospital. So, here we are. You or your loved one has entered the hospital space. Generally, hospitalization is an unplanned episode. Normally, it is not something you've expected to experience outside of those service lines that include labor and delivery. But normally people engage the hospital system when they're not necessarily looking or wanting to. When you find that you or your loved one have come upon occasion where you need hospital services, you usually enter into our space through the emergency room. Navigating healthcare is very complex. So the things that we experience with patients is sometimes there's a level of fear, anxiety when you enter those doors. It is also not a time when you're thinking about all the questions you may need to ask. Your primary concern is, my loved one is not feeling well. We need these services. We're here for help. The other pieces of the puzzle are not up front of mind, but they are important things that I'd like to speak with you about while you're not in that space, so that I could possibly help you understand it greater when you do encounter it and even know what questions to ask. So first, let's talk about who you may encounter. Normally coming in the emergency room, there are a host of folks. There's a lot of activity, but you expect to see a physician. Also, someone there to register you, to take information, nurses, case managers, and other team members. The physician that you see in the emergency room is that first point of contact, that first person who defines whether or not you need to continue your stay within the hospital space, or if they're able to bring you to stability and refer you to services outside of the hospital. The emergency room doctor is not going to be your attending physician. If it is deemed that you need to continue your stay in a hospital, there is another physician assigned to you to continue that care once the emergency room episode is complete. That attending physician could be your loved one's community physician. If they do indeed round at one of our hospitals, they may manage your care while you're with us, or you may be served by what is defined as a hospitalist. These are employed hospital physicians that care for you while you're in the hospital and then transition you back to your primary care physician upon discharge. So your loved one may see his or her own doctor, or they may see a physician employed by one of our hospitals. You'll also potentially encounter a specialist depending on what your loved one's needs are and what disease or what services are deemed necessary based on the assessment done by the initial physician. Your primary nurse team is usually the team assigned to you once you are deemed to require further hospitalization. And your case manager is the individual who will help to navigate and support the assessed plan by the physician and nursing team. And this would either be a nurse or a social worker supporting your stay. Additional team members may include therapists as well as dietitians, clergy, and other support services defined by the needs presented at the time of the hospitalization. So, it is determined that you've been assessed, you've been registered, and this is where at this time where you are asked about your insurance information, and this may happen prior to a physician coming in or after a physician has seen you. It just depends on the level of urgency in which you present within the emergency room space. This is how this is defined. A physician will examine you, and then they make this important decision. This is one of the points where I just want to make sure that if you don't take away anything else, you take away that you are to understand or ask the question of the physician, am I being placed in observation or will I be admitted as an inpatient? This is information that should be provided to you at the time of decision. Again, it's very, very important that you understand if you are being placed in observation or if you are being admitted as an inpatient. And we will explore those things a little further a couple of slides down, but I just want to make sure that the point of your level of care is one thing that you do take away from this information I'm providing you today, because it impacts other decisions down the line. And there is also a financial component attached to your level of care definition. So here we are. You're admitted. Am I observation or inpatient? The other things we want to think about during this admission is we want to gather information to assist with guiding decisions. We're going to assess your social and financial needs to assist with determining your transition plan and what supports we need to obtain or put in place. Also, although this may sound a little bit like how do you start discharge planning upon admission, it is something that we start doing, and we start doing it by gathering information. It is really, really important that we take the time to gather information in order to, again, support your ability to manage beyond the hospital stay. And another important piece of the puzzle is for you to share documents to help direct your care or your loved one's care. So if you are indeed supporting a loved one, understanding their wishes, getting direction from them, and understanding how you communicate with the overall care team is really, really important. What I'm going to do is I'm going to speak to each one of these bullets individually to go into a little bit more detail around each element. So let's start at that place where I said, this is really important. Observation. What does being placed in observation mean to you or your loved one? First, observation is a clinical level of care defined by your physician. It is a level of care that indicates either there is a disease state known that will be able to be managed in less than 48 hours, meaning you're not defined or assessed to need hospitalization greater than 48 hours, and therefore you will be placed in observation care. It is also a level of care that allows assessment or the determination of what has caused you to have these unexpected symptoms. Say there is not a known disease state. This time period allows the physician and team to assess your symptoms, provide testing, get test results, and then develop a plan, which may then lead to the requirement of an inpatient stay. But this time period was defined by Medicare and utilized by commercial payers to allow time to make a decision when things are either not clear or a less than 2 midnight stay will be needed in a hospital, in hospital's care. So observation services should not span more than 48 hours. Observation services are covered by your Part B benefit if you are a Medicare recipient. Commercial payers have an indication or a definition of observation, but they do not separate it by a part of the benefit. Your outpatient observation, your copay rules apply. So your copays in regards to testing, office visits, whatever percentage of your care that your copay designates, you will be responsible for that pay while you're in observation status. What you can expect when you're defined as observation, along with asking the question of the physician once the determination is made and they let you know you're coming into the hospital. The other requirement for the hospital, outside of responding to your ask, is to provide you with clear notification of observation status. The Centers of Medicare and Medicaid have designated that any Medicare patient who enters a hospital under the observation level of care is provided what is defined as the Medicare Outpatient Observation Notice, acronym MOON Notice. This notice shares with you, under your Medicare benefit, that these services are covered under Part B, that these services are the application of the copayment is a part of these services under your Part B deductible, as well as under regular Medicare, these hours do not meet the requirement for an inpatient subacute rehab stay. And I'll speak a little more to that a little later in the slides, but it is a benefit determination that impacts future decisions if you are designated in an outpatient level of care. I will also say there are some family members that may have their Medicare managed by a commercial insurance. Example, if you have an HMO like a Kaiser, a Aetna, that manages your Medicare, the requirement for the rehab services after hospitalization may be waived. And I'll speak more to that later. But under regular Medicare, non-managed, your co-payments apply. It does not meet the Rehab 3 midnight rule, and you should not be in the hospital beyond a 48-hour period. There should be a decision made by that time by your physician. Either you can return to community with additional supports or in follow-up, or you should be admitted as an inpatient. Let's talk a little bit about inpatient. Inpatient is a designation where there may be a known or an emergent symptoms that require hospital stay that your physician believes will be required beyond 2 midnights. This is an extended stay in the hospital that will require treatment beyond 2 days. It could be up to 5 days or 3 days. It could be any day period after a 2 midnight stay that your symptoms and management will require the level of a hospital to bring to stability. The inpatient designation also helps meet the 3-day requirement to access those rehab or subacute rehab services in a nursing facility if required or deemed medically necessary. That 3-day qualifier under Medicare is required. Again, if your family member has a managed Medicare, those rules may not apply. But under the Medicare under CMS, managed by CMS, those rules are required in order to access that further benefit if rehab services are required. Again, I'll speak a little bit later on the different levels of care and how you access them. What should you expect from us in regards to the designation of inpatient? Medicare requires us to provide you with this important message from Medicare. This notice should be provided to all Medicare patients, whether you're Medicare under CMS or if you're managed Medicare. The document does define the differences under the managed care definitions, but this message is just to inform you that if you do not agree with the discharge plan or have concerns about the transition, you have the right to appeal. This notice should be given to you when you enter the hospital, and if you stay beyond 3 days, it should be given to you again before you discharge. If at the time you're designated to discharge and the plan is in place, yet you don't, the patient doesn't, or the family or caregiver support doesn't agree with the discharge plan, you should be offered the opportunity to contact the quality management leader for Medicare to indicate that you do not believe or support the discharge plan. You are not in agreement. What will happen is they will ask you some demographic questions, some general questions. Then they will contact the hospital and let us know that you've officially appealed and request your medical record be sent to them. We have a time period within that day to get them the medical record, and then you have the right to stay in the hospital until a decision is returned. At the point of decision, if Medicare agrees with you in terms of the discharge plan is not adequate, you will remain in the hospital and continue to work with the clinicians, the team, to develop a safe discharge plan. If Medicare agrees with the hospital's plan and believe that it is reasonable based on the documentation and information, your family member will have up until noon the following day to discharge from the hospital without being liable for any payment. This is a notice again you should receive at the time you are deemed inpatient. And if you stay in the hospital greater than 3 days, you should receive a second notice reinforming you of your rights. Assessment. Now, with all of that going on, that was really informational. But during this entire time you're in a hospital, you will continue to be, or your family member will continue to be assessed throughout the stay. The physical assessment by the physician and the care team is ongoing in order to bring the condition, the acute condition, to stability and develop a care plan in partnership with the patient, family, and caregiver. The other assessment is a social assessment, which is led by the case manager, who will lead you with developing a plan based on your social resources, who's available to you, who is willing and able to support you if needed, as well as your financial resources, your insurance information, what type of benefit you hold, what can you access through that benefit in order to support the plan developed in concert with the physician and care team. You should be a part of these conversations and helping us develop a plan that is realistic for your loved one and also supports you as a caregiver. So this is what you should expect to be going on during the hospitalization with us. Discharge planning. I know I spoke about this happening at the beginning. It is indeed an activity that happens throughout the stay. Now, hospitalizations generally, on average, are less than 5 days. And as I spoke before, observation stays are even less than 2 midnights. So there's a lot of activity going on in a very short period of time. Also, understandably, this is a time when your loved one isn't feeling their best, and your primary concern is your loved one or even your own care during this time. With that, we understand that we may have to approach things in a different way, or even, engage and re-engage in terms of trying to assist with planning for a transition. It is really, really important that families and caregivers are a part of the planning so that there is no upon surprise or reaction once a decision is made or the determination is made that the family member is medically stable and ready to transition back into community. So I implore you to always actively participate and engage. And we'll speak about those documents and allowances that help drive and direct your ability as a caregiver to participate in the process. So let's talk about transitions back to the community. Know your benefits. So we talked about what am I in the beginning. It's important to know, am I observation or am I inpatient? We talked about the team you would meet when you came into the hospital and the different roles based on their position and what to expect there. We talked about the assessment process and the development of the plan during the hospital stay and the importance of participation at that time. We also talked about what that observation and inpatient may drive in terms of access to resources down the line and what forms you should expect to see and be able to review to help with further understanding of those levels of care. Now we're talking about what services can be accessed or may be presented to you for your loved one to support the transition back to community. Skilled nursing and rehab services are services normally located in a nursing facility, a nursing home facility, and it includes continued therapies with a team that consists of physical, occupational therapists, the nursing team, as well as other ancillary staff. The average stay in a nursing home for rehab services could be up to 21 days, but on average nationally, it's about 18 days. This is a level of care that requires, Medicare requires the 3-night inpatient admission. So that's where the importance of knowing what your status is when you come into the hospital, and if at any point it could change. You could change from an observation and go into an inpatient. You can also, important point, start as an inpatient and with additional information be assessed to only meet observation requirements. So it's really important that you ask those questions and you also look for information to help guide you with understanding the decisions your physician is making or your loved one's physician is making. Under Medicaid, skilled nursing and rehab is not a covered benefit. It does cover long-term care, but I'll speak to that a little bit down the slide. And commercial payers, it's policy driven. Here is where, if your Medicare is managed by an HMO, the 3 midnight requirement may be waived. But again, your policy drives exactly how you can utilize the benefit. Home health services are services that are used in your home where a nurse comes out to carry on the plan of care developed in the hospital, and those services normally include physical and occupational therapy coming to your home up to 3 days a week for a defined period of time. And that time is defined by continued progress based on the goals that you and your caregivers define. You, the patient, and the caregiver define. Medicare covers these services, and a hospitalization is not required for home health services. Medicaid also covers these services, and in both Medicare and Medicaid, a physician order, your primary care physician order, is enough in order to acquire or obtain these services. Commercial, again, it's policy driven. There are a number of policies, and they're defined by that actual insurer, but on average, this is a service that is covered even without a hospitalization. Home health and non-skilled support, these are folks who are non-nurses, non-social workers. These are folks who provide supportive services such as bathing, dressing, and even some do even light housekeeping, things of that nature. Under Medicare, It is not a covered service independently. Yet, if you have home health services under Medicare, an aide can be deployed to provide a task. So an aide can come out to help with a shower once or twice a week. So under that umbrella, you can access that additional service. Medicaid, this service may be covered under waiver programs. There is an application process and a uniform assessment instrument that helps define the need for these waiver services under a Medicaid insurance. And commercial, these services are normally only covered under what is a long-term care insurance policy, which is normally separate from a health insurance policy. But there are some unique situations where there is a combination of such. If that long-term care benefit is requested or added to a healthcare policy. Long-term care, this is a custodial care for support in a facility such as a nursing home. Medicare does not cover this service. Medicaid covers the service under a waiver, or you have to meet the long-term care requirements. And again, under commercial policy, the long-term care insurance benefit does support this level of care. Again, it is policy driven in terms of amounts that is covered during that time. Other things to really, really understand, and it's important to know, and I definitely want to just continue to drive home things around understanding your loved ones, as a caregiver, your family members, or your supportive person's insurance benefit. Copays apply to all outpatient services. I spoke about the observation. And this sometimes gets confusing again because people stay in the hospital overnight and they don't experience anything different from when they were potentially inpatient. In these cases, those copays do apply as if you were an outpatient, and that's for up to 48 hours. What that may mean is every service that you have, the tests, the services that are provided, you may be responsible for up to 20% of that stay. And that 20% could, on average, we get feedback, could be up to $1,500. So I just want to make sure I provide that insight about why it's important to understand what level of care your loved one may be in. I also want to say, from an insurance standpoint, not all medications are covered by insurance. So if your care plan requires a new medication, or your loved one's care plan requires a new medication, that may be something you may need to, or we should be speaking to you about. And if you do have a commercial insurance, we should be able to communicate to you whether or not it is covered, and or if you don't have a pharmacy benefit under Medicare, which is Medicare D, you may have out-of-pocket expense for medications. Now, a lot of medications, especially newer medications, have patient assistant programs. This is something that your case manager can help support you with understanding and accessing. Want to talk a little bit about benefit limitations. What we know for sure is Medicare does have specific benefit limitations. Commercial payers may as well, but they are policy-based. But I'm just going to speak a little bit about Medicare and the rules associated with that benefit. Medicare has, under Part A, has an initial 90-day benefit. So if your loved one happens to require a longer stay, which is not the norm, but you do have occasions where people are consistently in the hospital due to a disease state that requires that level of care for an extended period of time. The first 60 days of the 90 days are covered at 100% after your copay or your deductible is met, which is on average $1,260. And I know this is information that I definitely can provide you supplemental information on with the specifics. The next set of days, day 61 to 90, those days are covered at a percentage, full percentage, except a $315 copay for each day, but that's normally covered by a secondary insurance. So it's important for you to understand how your benefits work together, or how your loved one's benefits work together, or as a caregiver, how they work together. The 30-day period is when, you can access your benefit. If you're out of the hospital for 30 days, your benefit can regenerate. So if you're not hospitalized for 30 days, your benefit can regenerate again, and it could go to the 150 days. So let me specify that again. Let me specify it a different way. From day 91 to day 150, if you need an extended stay that long, you could go into what we call lifetime reserve days. So the last 60 days of your benefit are lifetime reserved, and they do not regenerate after being out of the hospital for even 60 days. And this, again, is information that I think we can definitely provide support beyond this presentation to help you further understand. It does get really complex with understanding how the benefit works, but is not the norm, or on average that individuals need to be hospitalized for that level, for that long. So it is not the norm to get to the point where you need to utilize your 60 reserve days, but there are times when we do see that happen, and we will have a clear discussion with the patient, family, and caregiver if we are anywhere near utilizing or requesting to use your reserve days. You also have to give permission, your loved one has to give permission to utilize the 60 reserve days. But here's what I'll also say to you. Whatever type of policy or insurance that you hold, it is important that you understand it. And there are services for those who have commercial and or Medicare to further understand. Even there are specific seminars to help individuals, loved ones, and caregivers understand the insurance benefit. So with
Pamela?
all of, yes, yes.
Yes. Hi. I know you're going to move on, and you're going to be talking about uh, papers, forms, and things. But I do have some questions about insurance, and I'd like to ask those of you now about the first bunch of information, because you have provided us with a great deal of fantastic information. Um, so one
Okay.
thing is if a person has a Medigap policy, and that would fall also under the people to contact, is that correct?
Yes, absolutely.
So you would want to make sure, because many people on Medicare do have Medigap policies, that you contact your Medigap policy provider as far as the copays and whatever else they will be helping to
Cor-
cover.
Correct.
Okay.
And they do fill those gaps. So those copays and those bridges between insurances, they provide specific benefit to help bridge between what Medicare will cover and what they will cover.
Okay, and that could vary, so you really need to contact them.
Yeah, it depends on who's the holder of the gap plan.
Okay, great. Another question I have here is, do I need to worry about in-network providers if I am in an in-network hospital?
No, you do not. The individual providers in your in-network are contracted under your in-network hospital. So as long as you're in an in-network hospital, I will share with you, Inova is not in network with Kaiser. So Kaiser patients who come to our facility, we work with them to transition patients to an in-network facility. But if you are in-network, any provider that sees you during that time is covered.
Okay, thank you. And also, you mentioned a case manager helping us. Does every patient have a case manager?
Every patient has access to a case manager. Case managers are assigned to patients who enter the hospital under observation or inpatient. I will say that we are not required to do discharge planning on an observation patient because the stay is generally less than 48 hours. But you do have an assigned case manager if you are in observation or inpatient in the hospital.
Okay, thank you. Um, how do you see insurance coverage changing, either good or bad, for older adults' hospital stays?
Well, there is a lot of policy work going on, and one of the bills that we presented through my American Case Management Association work is around the observation level of care and those hours qualifying or supporting the qualifying stay for rehab services. I think that's a huge opportunity that we're trying to um, um, even champion. And we do have Governor Courtney, who has supported the writing of our bill to help with ensuring that patients or individuals do not have to meet that 3-day qualifier in order to access rehab services if they are deemed needed. Because you can be in observation and being deemed to need rehab services in a subacute facility, yet if you are Medicare, Medicare will not pay for them because you don't have the 3-day qualifier. So in terms of benefit, Medicare is focused on doing a couple of things. First, making organizations accountable for providing quality care. So they're attaching quality to reimbursement for value-based purchasing. The other thing is they are requiring us to communicate. So those letters that I spoke to earlier, that observation letter, which in the state of Virginia, we are required to provide that to you within 24 hours, although Centers of Medicare and Medicaid give us 36 hours. The focus is making sure we communicate early. And the important message to Medicaid also wants to ensure that we're providing you your rights up front. So if you do not agree with our plan, you have the right to have it reassessed and reviewed by a Medicare body. So there are a number of activities. First and foremost, they are the world of healthcare. Of course, these are dollars that are heavily managed. These are also dollars that, in terms of expense, we spend a lot on healthcare, and they want to ensure that our quality aligns with our spend. So every initiative or regulation that they put forth is around quality and also around informing, and also the focus is to empower family members. So always speak out. There's always someone to speak to if there is a disagreement in terms of making sure that you have access to the services that you need.
Well,
Did that answer the question?
yes, and that actually fits in with a concern that somebody is expressing, and I realize, we're getting close to time and you have another topic to cover, but if you could give any quick tips about how to address actually putting the items currently that you were talking about into practice, such as actually meeting with team members, as some are only available when they make their rounds, non-continuity of team members, and lack of coordination among team members. So, do you have any good ideas for people who are dealing with those issues?
Well, here's what I would say. Your consistent team member should be your case manager. Of course, you may run into a time where there's a staffing, but there should be a hands-off communication. If you utilize that resource to then engage the greater team and define times you are available, we can meet with you as a team. Make the request. Have it be a part of the expectation. Communicate early. We will gather and we will meet with you. So please feel empowered, even if they say this physician rounds X. Yes, I understand that. But here's who I'd like to talk to about our plan, especially if you're hearing different versions of the plan from different team members. You have a primary nurse, you have a case manager resource available to you, and you have a hospitalist team members. With hospitalists, if it is not a community physician rounding, the hospitalists, remember, are employed. So they are available in the hospital all day during their shift. So if you can just designate and understand, here's a time when I'm available, can you ask that our team is able to meet at this time on this day, or even give a few options, that request should be met. And you can do that early in the stay.
Okay, I think that information will be very helpful moving forward for many people who've run into that.
Mhm.
All right, thank you. I'll turn it back over to
Okay,
you to
so
finish up.
sure. So after discharge, we're landing. So if you land or your loved one lands in any one of those areas, if you're in a facility, if you're home with home health, if you're home with non-skilled services, even if you're in a long-term care facility, your loved one or you as a caregiver should expect that your loved one or you should see or connect with your primary care physician within 48 hours of discharge, or a community physician. So in facilities, of course, there's a physician team there, which may or may not be your primary care physician, but that physician should see you within that time frame after you've left the hospital. If you're going home with home health, same. You should be seen by your primary care physician within that time frame. And or if you're going to home without any skilled services, and a physician should see you in a long-term care facility. This is important because, again, we spoke to, while you're in the hospital, most patients are seen by hospitalists, employed physicians at the hospital. We want to make sure that your primary care physician understands that episode of care and is there to continue to manage to prevent your need or the need for you to be rehospitalized. So that's why it's important to connect the acute care setting with the community setting in terms of providers. So this is one of those other like red flags. This is an important piece of the puzzle in order to ensure that you don't end up in a space where you need to be rehospitalized. Please connect with the primary care or lead physician in community that serves you and or your loved one. Going to speak a little bit, I know I'm running on time, about documents that are important. Decision makers. So advance directive is one form of decision-making tool, also called a living will. This is a document that helps support caregivers, loved ones with carrying out the individual's decisions if they're not able to speak for themselves. So this is a document that is known in community, and what we try to ask this question every time your loved one is hospitalized to know if there is indeed an advance directive in place. Have you given us direction? We usually, if we have that information, we'll usually validate if it's still the same or has something changed. So that should be a normal part of the ask if you're hospitalized or your loved one is hospitalized. The power of attorney, this is one that covers anywhere from financial to healthcare. And this is one that's more familiar with in community. And it is one where you can designate different people based on what healthcare or financial services, and we can utilize that as well. But again, the designation is employed only if the patient is unable to speak for themselves or defers to a caregiver or family member. The post I'm going to breeze over because this is one that I want you to take back to your primary care physician or to talk to in depth. This is where physician orders are signed. You direct what you want the physician to do, so they don't have to speak to anyone or contact the power of attorney. Of course, they'll review what you want, but these are their orders, and there are many educational series and experts that can further define this. But I think this is language and information that I definitely wanted to include here so that you can arm yourself with this question the next time your family member or loved one goes to their primary care physician. Rounding up, what you can expect from us. This is really, really important. As I round up, you can expect clear, consistent communication from the team. You can expect goals of care to be shared with your loved one or the person you're the caregiver of. You can expect patient-specific education. What caused you to need hospitalization? You can also expect resources and services to help you manage health beyond the hospital stay. Expect to be a part of the plan, and we expect you to ask us questions. So please do not hesitate. I want to thank you so much. I know it was a lot. I'm hoping it served you well. I will remain a resource. I've provided my contact information here. Would love to hear your feedback. Would love to also, if you have additional questions, provide an avenue for those questions to be answered. But I appreciate your time and attention. Thank you so much.
And thank you. That was a lot of information, and you presented it very clearly. So I know we all benefited from that. I would like to tell everybody thank you for attending. The webinar was recorded, so I will be sending out a link. You can listen to it again if you like. And also, as you sign out, there will be a brief survey. So if you would please give us some feedback, we appreciate that. It helps us moving forward. So thank you again so much, Pamela, and thank you everybody for attending. Bye now.